So welcome to the 2022 annual event. This is our 9th annual event. Welcome to Dr. Paru Rayudu for being here representing the Rayudu Family and Friends Endowment. And we have a lively program going on today that so we started this morning with a breakfast with representation from the affiliates across the consortium and had 4 rooms of poster presentations. And we have scored our top abstracts in that poster session that we will reveal in our awards section following the platform presentations. We're excited about our keynote presentation, which we will introduce in just a short minute. And please stay after the break for our oral platform presentations, which were the top 2 abstracts in the student category and the top 2 in the resident and fellow category. And then we'll close the afternoon with our recognition and award ceremony. But thank you for those of you here representing the different affiliates. Over the years, your support has made this program grow and be as robust as it become. So the mission of our consortium is to lead in the scholarship and dissemination of local, regional, and national activities directed at enhancing quality improvement and patient safety initiatives. And our goals have been focused around our robust QUIPS curriculum that's growing around problem-solving methodology. And we're working really hard on improving our QUIPS scholarship locally and nationally, going from abstracts and platform presentations to hopefully publications in peer-reviewed journals. We're providing a number of different resources for faculty and students so they can do their own QUIPS-related projects driven from the grassroots up. And we're looking to facilitate deeper collaboration amongst our affiliate programs to be able to share across UMKC and the affiliate hospitals. And we're proud to have a community member on our advisory board who can help support quality and safety initiatives in the community and help our students and trainees conduct projects using those data sets as well. So we have a rich program history beginning in our first Quality and Safety Day in 2014. It's changed a little bit over the years, especially in these last few years, going from a virtual program to a hybrid event this year. So I think we're getting some good reviews on at least having the opportunity to be here in person. Our past keynote speakers have come from various backgrounds and have continued to take a stage in the public forum. And I'm so pleased to add to this list today's keynote speaker that I would love for Dean Jackson to come to introduce. And thank you so much, Dean Jackson, for your support of this program. It wouldn't be what it is without you.
Okay, I do need my glasses on. Hello, everyone. Thank you for being with us today as we celebrate in person the 9th Vijay, Babu, Rayudu Quality Improvement and Patient Safety Day. We're grateful to have with us today Dr. Paru Rayudu, our 2012 grad and representative for the Rayudu family, without whose support this day and our work would not be possible. We're also honored to have with us today Dean Emerita Betty Dries, who was instrumental in creating this program and this affiliation. And also our Rayudu Endowed Chair, Dr. Mamta Reddy, who's done an incredible job in developing this program and advancing our work. We're thankful for all the talented students, residents, fellows, and faculty joining us today to learn, to be inspired, and commit to support the goals of the Quality Improvement and Patient Safety Day Consortium as we innovate educational programming in quality and safety science, build organizational infrastructure, and support academic scholarship for all levels of learners. So today, we welcome our keynote speaker. I'm going to take my mask off for a second so I can be clearly heard. Dr. Chris Moriarty's, an associate professor of internal medicine, a hospital medicine physician, assistant dean for healthcare value, and associate chair of quality, safety, and value at the Dell Medical School at UT Austin. He is also the executive director of Costs of Care, a grant-supported not-for-profit that uses advocacy, education, and technology to help patients address medical bills. This organization has been featured in the New York Times, on NPR, ABC television, and within the New England Journal of Medicine, as it uses narratives from patients, nurses, and physicians to highlight how we can improve the value of care. Were published, And an added perk, and I love this piece of his history, is that he was a music aficionado and band member. And among those 70 articles that were published, he was sent to concerts and got to interview backstage a lot of your musical heroes. So I think that's so cool. After medical school at UCSD, you continued on as a resident and specifically got engaged in work to highlight cost awareness in medical care. So and for all of our trainees are here today, and I think listening to the story of someone who found a niche, capitalized on a passion, and then took this into his career is very inspiring. His work in cost awareness led him to an invitation to join the ACP's High Value Care Curriculum Committee, and the work he did there set him on a path to ensuring the culture shift necessary to make this work a reality. This past year, he was inducted into the UT System Kenshine Academy of Health Science Educators and the Dell Medical Academy of Distinguished Educators, and awarded the Outstanding Educator Award at Dell Med. Among the numerous other awards he's received accolades for a book that he authored called Understanding Value-Based Healthcare with two collaborators of yours that was published in 2015. And what I loved about this book is in the introduction, you indicate that the primary audience is physicians who care for patients and spotlight situations where, and I'm going to put quotes in here, our misfires can be devastating. When patients are blindsided by bankruptcy inducing bills, and patients are subjected to end-of-life treatments that overlook the fact that most people have other goals besides simply living longer. The discussion of improving the patient experiences by tracking outcomes and engaging in shared decision-making is highlighted, and the concept that those caring for patients day and night should be leading from the front and not trailing behind. It is this sentiment today that will inspire us as we hear from Dr. Moriarty, learn from our platform presenters later, and celebrate the awards to those who have woven quality improvement and patient safety into their purpose. So Dr. Moriarty, welcome to the UMKC School of Medicine.
Thank you so much. Wow, thank you, Dean Jackson. That was the kindest and most personalized intro I've ever received. I need you to rewrite my bio on the website. It was very nice. Okay, so let's see, this is a word. Let's try this. So if I do this, okay, great. It is such a pleasure for me to be with you all. This is my first trip to Kansas City. And it's been so nice to hear the great presentations this morning. I look forward to the presentations later. And the stories that I've heard and this example that the Rayudu family has set is just really inspiring, and one that I've been sharing with my colleagues in Austin all week, talking about how excited I was to come, and one that I will share when I get back. So thank you. I don't have any disclosures for this talk. As I mentioned, it was my first trip to Kansas City. So I said, well, do you have any barbecue recommendations? And Dr. Reddy sent me a decision tree. And I thought, oh yeah, I'm going to the right place. These are my people, which was wonderful. I want to talk today about how we set culture and how no matter what your role is, whether you're a student or a resident or an attending physician or a dean, what our role is to lead from where we stand. And it makes me think back to what now is actually years ago. And I stood at the foot of the bed and I said, do you have any questions? And when I said, do you have any questions? I immediately could see my residents and medical students like shoulders start to slump. They're like, oh man, we got 13 more patients to see. We got to get to noon conference, got to keep moving. And when I said, do you have any questions? My mind immediately started to chant, please don't, please don't, please don't, please don't. You guys know that chant? My patient, an elderly woman, admitted with shortness of breath. She had a malignant pleural effusion. Her cancer was trying to drown her from the inside out. something she didn't even know was possible until now. And I could see the fear and uncertainty in her eyes. And she looked at her daughter at the bedside, and then she locked her eyes on mine. And even though I thought the chant was in my head, she could read my mind. And so with a sigh of her own, she said, "No, thank you, no questions." What do? We just went, phew. And then we left. Med students, residents, me, pharmacists, all out, gone with the efficiency of a Broadway scene change. I left with this feeling like, what the heck? This isn't the doctor I want to be. It's what I came here to do. And I was at UCSF at the time, and at UCSF, as elsewhere across the country, we were setting our sights on improving the patient experience, which meant new C-suite level positions, new acronyms, and of course, mandatory online modules, because I know you know as well as I do, there are always mandatory online modules. Here's the thing. Those things are necessary. It's important to codify our best behaviors in that way. You have to say, like, this is what we're trying to do, and this is how you do it, and we're going to teach you. But that's not what changed culture. It's not what I think changed my behavior. What I think changed the culture, what changed my own personal behavior, was mostly Diane Slitka. Diane was a hospitalist like me. She had no formal position or title or formal responsibility to do this, but she found interest in it. She went to training. She learned about patient communication. She came back, she taught us, and she led by example. And some of the things she taught me felt like magic, because it was such a small little shift and yet so profound. So she taught me to say, what questions do you have? Instead of, do you have any questions? When you say, what questions do you have? One, please don't chants no longer apply. And it completely transformed the way I ended my visits with my patients. Because of course you have questions. Of course you do. And I'm inviting them. And you're like, oh, I don't have time for that. Turns out, doesn't take that much longer. Saves me the page in the afternoon from the nurse telling me that the family is confused. And what the hell else am I supposed to be doing? What's more important? She taught me to say thank you as I left the room, as opposed to like nothing or like, well, see you later. It felt weird at first. Thank you. And the patients go, no, thank you. And it's really nice. But here's the important thing. What Diane did became institutionalized, because we did it, we taught others to do it, and suddenly I'd be in a room with a resident I'd never met before, never worked with before, and I'd hear the resident say, what questions do you have? And I thought, aha, we are part of the same culture. We care about the same things. It just became what we do. And in fact, it's so deeply ingrained in what we do that now, more than 10 years later, after learning this lesson, I have to remind myself at the beginning of giving this story to say, do you have any questions? Because that phrase just like does not come off my tongue anymore. It's hard for me to say. What questions do you have? So I want us to think about, as we talk today, how, despite, by the way, Diane now does have formal, she's like chief happiness officer or whatever. I don't think her title's that far off. But she at the time didn't. So whoever we are, how we can do that, how the little things we do transform the way we provide care and the way we practice. Okay. I'm going to be a little jumpy with the here, but we'll do this. So here's what we're going to talk about today. I want to talk about leveraging learners as leaders. Then I want to talk about specific key elements to influence effectively, even when you lack power. And then we'll finish by talking about supporting change through role modeling and systems. I hope to leave time for questions, but I have to say we're a little bit behind. So if we don't, I'm here all day. I'm going to welcome questions throughout the day, okay? All right. Learners as leaders. This is a lesson that I learned in 2015, 2016, when some of my colleagues up in Canada, Brian Wong, Karen Bourne, Wendy Levinson, they started a program called Choosing Wisely Canada STARS, where they got 2 students from each of the 17 med schools in Canada, 17 med schools in Canada. They got 2 students from each one. They brought them to Toronto. They taught them about choosing wisely and healthcare value and leadership and advocacy. And then they sent them back to their schools and said, do something with it. And they supported them to go back, and the students like started interest groups and journal clubs, and some of them made curricular changes, and some of them met with their deans. And it was this whole push to introduce choosing wisely and value into their curriculum. And I was on the advisory committee, and at the end of the year, I was hearing about what the students did, and I'm like, oh man, we need to do this. But here's the big lesson that I think I knew. I knew that med students are incredible and could lead. What this showed me was that they weren't leading despite being first-year med students. I think they actually were successful and effective because they were first-year med students. Because they were able to introduce changes that didn't feel like it was happening to their class, it was happening with their class. Their colleagues jumped in and supported it and wanted to join and support their friends rather than the dean telling them this was a new initiative and LCME says we should think about value. So we collaborated with those same colleagues from Canada and started STARS here in the United States to bring medical students, usually first-year students, to teach them about those same things. And we're actually in our current 5th cohort. I'll note we've got schools across the country. We don't yet have UMKC, so I'd love you all to join us next year. We have had over the first 5 cohorts more than 450 med students. 80% of them in a given year started an initiative at their schools to stimulate student discussion about choosing wisely and high-value care. 60% of the schools implemented curricular change. That's huge for those of us that do med ed. That's not easy to do within a given year. Some of them were like electives or high-value care electives, but many of them were actually integrating it within their own curricula. And then we actually just surveyed the second class who just matched, but I don't have those results for you yet. Actually, probably could crunch them on the plane ride home. But during the first class that matched last year, 60% of them responded. 100% said they included on their application. Not surprising, but it was their first year that they really participated. 77% said that it was a prominent thing they talked about during their interviews. And 100% said the exposure to the STARS program had a positive effect. And actually, since then, as we've grown the cohorts, it is now much more longitudinal. Then it really was sort of like a first-year experience, and we kind of kept them engaged. But now the students are STARS for life. We also started a model, and I can talk about this later in the afternoon, I know with our advisory board and others, but in the residency program, we created a distinction track and care transformation at Del Med with the idea that we want our residents to come to Del Med not just because they want to be outstanding physicians, that's first and foremost, but they also want to learn how to lead and change the system. So they don't want to just learn how to treat the patient in front of them, they also want to learn how to treat the system around them. And so these students, or these residents, come and they take part in our clinical training, but in addition to that, we have foundational curricula for them around safety and quality improvement and value and leadership. And in design thinking, and then they actually have a little bit of protected time. It's really just 1 month during their second year and 1 month during their third year, but to advance mentored projects. So they run mentored projects during their second and third year, and they have this extra time to kind of help consolidate or move those projects along. And they've done incredible things, but I'm going to focus on the most incredible one, in my opinion, which came from our first year of the program. Nick Christian, right there, was one of our very first distinction track residents in internal medicine. And he had a passion that he wanted to improve care for patients with opioid use disorder. He had a personal story about it. It was meaningful to him. And he really helped spearhead this creation of what we call the B team. The B team is the buprenorphine team. We've got hospitalists, we've got pharmacists, we've got a chaplain, we've got a social worker, we've got a psychiatrist, all of us working together in order to change the way that we provide care to patients in the hospital who have opioid use disorder. Prior to this, we saw a lot of patients coming with epidural abscesses, endocarditis, and we would like treat that problem and ignore the underlying cause. I say it's like pumping up the tire without ever looking for the nail. You just keep pumping it up and you send them out, and then you're frustrated when it comes in flat again. So we started looking for the nail. We started doing something about it. And we started treating patients with buprenorphine and then making a handoff to our local FQHC. And we published the results of the first 2 years in our small 210-bed hospital. We had seen 260 patients, or been referred 260 patients. Many of them, half of them pretty much were not eligible for lots of different reasons. Either they already were on like methadone or bupe, or they really didn't want to start, so on and so forth. But we were able to get patients started and bridged. And 24 of them, which sounds quite modest, but this is like actually as good as any intervention's been shown, were still engaged, still attending appointments and still on buprenorphine more than 6 months following their discharge. And this program has grown. So we actually have now received more than $1 million in funding from Texas HHS to share that model of hospital-led intervention, using hospitalization as a reachable moment for folks. And we're on track to treat more than 1,500 patients across our 5 partner sites that have signed up as part of this program this year. And that started because of Nick. It obviously grew much bigger than Nick. And I write the grants and whatnot, but Nick was the one, this would not exist. And actually has become like 30% of my job, by the way, and was something that I had no interest in, but Nick inspired me that now this is a major part of my own career. And that is the power of building a pipeline of change agents. That if we can create that energy from med students on up, we can really have an impact. And the important thing there is because trainees, it's one thing to really focus on what we're going to do here in the consortium. It's a great example of like focusing on improving patient safety here in Kansas City. It's great. We can do even more than that because our medical students, our residents, our fellows, they will go on and reach all corners of our medical system. I have one of your UMKC medical student graduates. And when she was on the wards with me, I said, oh, I'm going to be going up. She said, oh, quality improvement is a big thing there. Like she's talking about it. And she was aware of this, this initiative. So they will reach all corners, all different specialties, and be able to really help us build the type of healthcare system that we want to see. I've increasingly come of the mind that that's really the only way we're going to do it. Only way we're going to do it actually is having a generation of health professionals that are trained and are looking for something different from our health system. So this is Nick's going away. We're teasing him with Dr. Mustache shirts. But he is now an addiction medicine fellow at Yale. So we said, oh, you went from y'all to Yale. And taking his place was Rich Botner, our PA, who really led the B team successfully to grow it to all those other hospitals. And that's now Rich, moved with his wife to Colorado because he's the director of patient safety and quality for the Colorado Hospital Association. Is this a bummer? Yeah, it's a bummer, but you know what? We have a pipeline of change agents. So Jan Ramesh was our hospital medicine fellow in quality and safety. She trained during a year on quality and safety, and she now has taken the reins, not just to help do this work, but to even advance it further. And we actually, I think, are supposed to find out today about what I think is a really exciting grant proposal to expand this work to alcohol use disorder and tobacco screening within hospitals. We're going to do AUD, tobacco, and OUD within our hospital if we get this funding. So I think we will. So learners can lead, not despite being learners, but because they are learners, they actually can be more successful, I think, and we need to support them. Create that scaffolding, create that environment, create that culture. Let's talk about, though, how do you lead? What are those key elements to influence? Because let's face it, if you're, well, pretty much all of us, except for the dean, lack power. So you need to be able to influence to bring people along. And there's lots of different definitions that you will hear about leadership. Here's one that I was taught that stuck with me. Because people oftentimes think of leadership as positions, as titles. But it's much less and much more than that. In order to lead, you need 3 key components. You need a vision. You need a vision of what you're trying to achieve, a vision of something better, whatever that might be. We hear all the time about visionary leaders. Great, but I want to tell you, vision alone is not enough. If all you have are visions, that's psychosis. You need more than vision. You need vision and you need a task. How do I get there? How are we going to get there? You don't have to be right, but you got to have at least accountability, responsibility. I'm not just laying out visions. I'm like laying out visions and saying, and here's what we're going to do. And I'm there with you. I'm responsible for us achieving that vision. Got a task. And then you got to have relationships. If you don't have relationships, you're kind of just on your own. So you got to be able to use relationships to lead people and bring them along. So all of us, no matter who you are sitting here, can have a vision of something you're trying to achieve, a task or responsibility to do it, and relationships that we can use to move along. And we're going to do it. Oh, so I wanted to say, I know you all can do this. I watched Kayla's great example from last year. Kayla has what it takes. She had a vision about what she wanted to do. She took responsibility to achieve it. She worked with others. I saw lots of examples of that this morning for many of you, showing that you can work with nurses and doctors and others in order to improve the experience for kids who have to undergo colonoscopies. That's cool. So we have that potential to lead. But how are we going to do it? So I'm going to cover how we use influence. And there's two types of power usually that we can flex. The first is positional power. This is what most people think about. This is like, oh, when I'm the attending, when I'm the chair, when I'm the dean, when I'm the president, like things are going to go my way. This is the power to reward, to discipline, to have authority. We all have that on some aspect of our lives. Any of us that are parents, certainly, that comes with the territory. But also we know that there's serious limitations to this. People resist positional power in overt and covert ways. You can flex it. I can make my kid do what I want them to do, but it's not easy. It's not easy. So positional power is actually quite limited. We can use personal power. Personal power is drawing upon our own expertise, our own information, our own goodwill to bring other people along with us. Kind of like I think of social capital, like social capital. So how do we use our personal power? This is the power that the med students were pretty much pulling upon. You know me, you like me, you trust me, I'm one of you, here's what I want to do, and people come along with them. You can use personal power. But how do we do it effectively? And so we're going to talk about influencing. And I have to tell you that when I'm talking about influencing today, I'm talking about something you do, not something you have. And I have to say that because I know our med students and others live in a world of influencers. It's like you're an influencer. It's like something you are or you have. No. Influence is something you do or don't do. It's about moving someone to a choice or commitment that supports your goal, whatever that goal might be. Whatever that goal might be. You got to move people to come along with you. And so you're going to use influence. And I want to pause for a second and say, you may, like me, get a little bit of this icky feeling when you hear words like influence and persuasion, because it feels like, oh, am I being slick? Are we learning how to be, used car salesman? And that's not at all what I'm trying to talk about. I actually think about the key elements that we're about to discuss as things that you can't not do. The only question is whether you do them intentionally with purpose or unintentionally. I think about it as like this big sword that I have. And I'm either aware that I have this big sword, I'm trying to swing it intentionally to hit my target, or I'm like unaware I've got this thing. And I swing around and sometimes I hit my target and sometimes I make a mess. And that's what happens if we're not trying to harness these principles. So 4 key elements I'm going to go over with you. We're going to do each in turn with examples. The first is you have to establish credibility. And as we'll talk about, credibility really grows out of 2 sources: experience and relationships, or expertise. 2, you have to frame for the common ground for your audience. 3, you have to provide evidence. Talk about how to do that most effectively. And 4, you have to be aware of and match the emotional energy and receptivity of the audience. All right, go with me? Please, people online are still with me. All right. establish credibility. If you're trying to get someone to do something with you, whether you're Kayla or whether you're our student trying to improve colonoscopy preps for pediatric patients, or trying to get the outpatient clinic to screen for food insecurity, examples I heard this morning that were great. The first thing people are going to say when you approach them with this idea is like, can we trust this person's opinions? Can we trust this person? That usually can only be established over time. So like for me, for instance, if I go on Twitter, God forbid, right now, there's like 100 people who I can look, they're going to tell me exactly what I should be doing about COVID. In fact, if any of you tweet this picture, I'm going to get like, you have no mask on. I'm going to get freaked out. Now, I'm going to say automatically in my head, I don't even realize I'm doing this, but I'm going to size people up. You're like, okay, this is Bob Walker, who I don't always agree with, but like I know and trust, and I know where he's coming from, and I'm going to take his advice and say like, yes, I can trust this person's perspective and opinion. Like, this is good, but I can trust it. Or is this, some random? The only way we usually establish that is because people know your results or know you. It's why we have these big bios in the beginning, right? Like, why before I got up to speak, we feel the need to tell you who I am, because it's like we're trying to say, oh, you should listen to this guy, even if you don't know him. So track record. So what do you do? I actually am, it's not going to be rhetorical, I'm going to use you all in the room. What do you do if that's your area of weakness? Like, what if you're a first year med student, you're like, I'm not a QI expert, but I was asked to lead this project. If your area is expertise, what can you do to still establish credibility? That's your question. Yes, attach yourself to someone with credibility. I'll say more about that in a second. That's huge. What else? Show up, engage, create a track record. Yeah, show up, create a track record, engage. Go and learn, like either formally or informally, get some education, get some credibility. Definitely. Use outside sources. Okay, so here's some of the examples. So one, learn more through formal and informal education. Like if you are I know I use the example of medicine, but faculty, you're faculty and you're like, gosh, my way to promotion or whatever your reasoning is, you want to be able to lead these projects, what should you do? Well, you should join the faculty program. That runs the faculty scholarship program. Like that's how you learn and get some credibility. When I wanted to do cost awareness curriculum as a resident at UCSF, it's like, oh, I think I want to do this thing. I tried to learn as much as I could. I read, I dove down as much as I could, informally. But I had to ask, like, do I need to go get an MBA? Do I need formal education credibility or not? I was walking with a friend around the lake recently, and she was telling me about her goals and trying to figure out what she was going to do. And at the end of it, my insight was like, Shonu, it sounds like you really want to do policy on like a big level. This is going to be your career thing. I actually think that the type of things you want to do, the only way you'll have credibility is formal. Like you need to go do a policy fellowship, or sometimes you like actually just have to go do the work, or you're just not going to be credible. So formal or informal education. Tap experts within the organization to advocate for your position. That's huge. Their credibility becomes your own. Find the expert, find the faculty mentor who's going to come with you to the meeting, or find bring Dr. Reddy, or at least drop her name. Bring the experts. This is not just my crazy idea. So when I was doing the curriculum, I had a chief resident quality and safety. I had a faculty member and these others who I brought on board first before I went and said I wanted to do this. I bring them with me. I still do this all the time. I bring Lucy Latham with me to meetings because she's got credibility within our organization around operations, and I know. Use outside sources of information, so studies, articles, choosing wisely materials to say, like, once again, not me, not my crazy idea. This is out there. The evidence says we should be doing this. This is a gap that's been identified. Why do we not do it? And then lastly, build your own track record, launch pilot projects. So I wanted to start this cost awareness curriculum. I could have gone and said, hey, I want a monthly noon conference. And they would have looked at me and sent their resume like, no. What are you talking about? I didn't do that. I said, can I try this thing as part of my health professional education? Pathway is a project. It's easy for them. And I said, I want to try it once. We're gonna review a bill, and then we'll present it like an M style case in the conference, we'll collect anonymous evaluations, see how it goes. Okay, went pretty well, for the evals, and we tried a couple more times. Then it was time for me to say, can I have a monthly meeting conference next year? Now we can say yes, because I have a track record. Mike Brode's a colleague of mine. He was a first-year faculty member when he landed in Austin, and suddenly there was a COVID switch. And here he is, pretty much first-year hospitalist. He doesn't have credibility. He's not infectious disease trained, so he's COVID-19, but he's really, really smart, really great. And what did he do? He, one, dug into the evidence. Like, you trust, very quickly you learn that Mike Brode is going to know the latest study, dug into it, thought about it. And so he educated himself in a big way. Two, he surrounded himself with experts. He created a therapeutics and informatics committee that had infectious disease and critical care and pharmacists and evidence-based medicine people. And they met frequently during the beginning of the surge. And they would review the evidence in real time and help make guidelines. And suddenly, Mike Brode now is our trusted go-to person. And he's like speaking nationally at SHM. And like, I mean, just if you want to look from a careerism, it's like launched his career in a huge way. Why? Because he was thoughtful about establishing that credibility using all of those different ways. All right. Second, you got to frame for common ground, which means illuminate the advantages for your audience, which means you know what those advantages are. It means you have to do work to understand your audience. I didn't notice. No, all right. Means you understand your audience, which also, by the way, is like the bane of my existence as an academic physician. I'm like, you mean we're going to have a meeting for the meeting? I hate meetings for the meetings. But I've also learned to not hate them so much, because I'm like, the last thing I want is to be in a meeting with my CMO and not know what the colleague sitting next to me is going to say. You know, the last thing I want is to be pitching something and be like, oh my God, you know, my friend is actually going to like swipe me because I don't know that she actually thinks this is a bad idea. I need to know that before I'm telling my CMO. So we need to understand what matters most. So with the B team like would present slightly differently. When they'd come and talk to the residents, Nick Christian would get up and he would lead with his story, his personal story about his friend. He would talk about why this was so important. And you talk about why this is the right thing to do and the evidence around why buprenorphine is so effective, so on and so forth. When we would go present to the C-suite at the hospital, it's not that they don't care about those things, but we led with like, the evidence shows this decreased length of stay, the evidence shows this decreased AMA discharges, and it's the right thing to do. And let me tell you about these great, you know, pulling your heartstrings. But really we led about with some of the length of stay data and the readmission data. So that's illuminating advantages. Provide evidence. Evidence, we think, is all about data, but it's not. It doesn't matter who you're speaking to. You're like, oh, but I'm speaking to, you know, a scientist or, you know, the most data-driven CFO. Like, okay, you need the data, but guess what? We're all human, and we actually respond most when you appeal to both our heart and our mind. The data is important, but the stories, the metaphors, the examples, the analogies help that data come to life and help people get more engaged in wanting to do the work with you. Kelly Bagwell, great resident of ours, distinction track resident, third year, gonna be a chief next year, and then an infectious disease fellow after that, started a project around penicillin allergy delabeling. And when she first was presenting it to us, she was telling us all about how the IDSA has made this a goal and it's so important and blah, 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 blah. And it was great, it was compelling. But at the end, I was like, Kelly, why are you doing this project? Like, I know you want to be an ID fellow, great. But what, she said, oh, I had this patient and like they said they were allergic to penicillin and we used second choice antibiotics and they had this bad outcome. And I looked into it and it turns out that's actually relatively common that these things happen and there's adverse effects and blah, 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 blah. And so this is the project I want to do. I was like, lead with that. You still want the data, you still want the IDSA, we still need to tie it, but tell your residents, because suddenly they're going to care much more that this affected you. Atul Gawande is the master, I think. Anybody who reads Atul Gawande? Yeah. Atul Gawande tells you about McAllen, Texas, and then tells you why it's not about McAllen, Texas, puts it in context. Or tells you about this patient that got an avalanche of unnecessary medical care, and then tells you how common that is and how it affects us all. You want to appeal to both sides, and it's really important. Okay. Fourth element to persuade. Match emotional energy. I've actually got lots of stories about this over the years, but I'll use this one for now, which is to say, you got to understand where your audience is able to receive things. So when we were in the middle of our COVID surge, it doesn't matter if you've got a great project idea. If you go in and your energy is like, hey guys, actually here, I'm going to tell you. So we just launched this Building Trust initiative, which is part of the ABM Foundation, like national campaign. And so it's all about like, how do we build trust? And I need to collect ideas and we're doing this thing. And we were going to launch it a couple months ago and we were going through a COVID surge. So here's the thing, like if I go in my hospital and I'm like, hey guys, we've got this great thing. We're going to talk about building trust and we're going to do this idea campaign. And our nurses are like, are you freaking kidding me? Like, do you work here? Do you see what's going on? Like, not the time, man. I think we need to recognize that sometimes people are not going to be receptive to the message if it's not matching the experience and the emotional energy where they're at. Now, that doesn't mean that we're like, got to all be burnt out and depressed, but it does mean we have to recognize and say, this is where we're working from. And come in with the right type of energy. Okay. So common pitfalls, where do we go wrong? One, doing the hard sell up front. We mess this up all the time. Part of the reason is because we think that it's a one-shot effort. We're like, this is our one chance. It's my one chance to sell this to the clinic leader, to the faculty member, to the whomever, okay? Almost nothing that we want to do that's important is going to be a one-shot effort. Relationships, leadership has to be over time. So I say your goal is not to convince them to marry you, it's to get a second date. All you need is a second date, guys. You want them to get coffee with you. If you go on the first date and you try to convince them to marry you, that's doing the hard sell. If I went in and said, I need a noon conference and blah, blah, blah every month, of course you should give it to me, like, didn't work. So we got to recognize it's not a one-shot effort. We shouldn't do the hard sell. The reason the hard sell doesn't work too, by the way, is because naturally we match the energy. So when you sense that a hard sell is coming, you actually brace yourself. Even if you love and respect and know the person, you like brace yourself because you're like, whoa, I don't know, they're trying to push me over for some reason. And so I'm going to resist getting pushed over. And so people start to resist if you come in guns a-blazing. Not being willing to compromise. Great resident, distinction resident, had a project idea, wanted to change the way we treated alcohol withdrawal and alcohol use in our hospital. And so he did the research, worked this up, and basically said, okay, I want to change our alcohol withdrawal protocol, and he want to change like a ton of things. And it sounded nice, and I was like, okay, but we started to quickly learn that there was going to be a lot of resistance to each of these parts. So I said, like, Chris, why don't we concentrate on like one thing right now? Why don't we actually just work on identifying the people who benefit from naltrexone and getting them naltrexone and follow up? And he was like, no. It's all or none for me. I mean, really, that's not exactly what he said, but really that was his attitude of like, no, I think we need to do this whole project. And it was like, okay, like, you're not going to get anywhere. And he did it. And I mean, he did another project. It was great. He graduated. He's fantastic doing what he's doing, but he didn't do that. And now we're starting a program where we're starting naltrexone and we're starting and now people are saying, maybe we should look back and start to change our withdrawal protocol. Because we've gotten in, it's different. We've been willing to compromise, and now we can get to where we want to get to. And then thinking that only great arguments will work. It's not about great arguments. It's about relationships. It's about stories. It's about the situation. And sometimes you could have the best argument in the world, the best reason why someone should do it, and it's COVID, and like, sorry, it's not going to happen. Or it's like stuff you don't even know, like, oh, the CMO actually hates that chair, and she's just never going to support this. Like, too bad. So it's not just about great arguments. We got to find where we can go. So speaking of coffee, speaking of great arguments, I want to give an example and talk about the morning lab for a minute. I'm a hospitalist. I kind of love the morning lab. Like, it's just something that like got ingrained in me during residency, right? Like I come in the morning, I get my coffee, and half consciously, but very deliberately, as I stir the milk in my coffee, I review the labs and I replete potassium like a ninja. I stomp out so much hypokalemia. And it's like, it just feels comforting that I see the labs every morning, first thing when I come in. And then it's like, no, man, we need to stop doing that. Choosing Wisely campaign. It's like, why are we getting routine labs on everybody every day? And truth be told, when I started my faculty position, I said, we're going to address each of the things on the Hospitalist Choosing Wisely list. And one of those things was to stop getting routine labs. And so I started to tell my colleagues, and they started to pull out all kinds of war stories about like the CBC. So we're going to decrease the daily CBC. And they're like, oh, let me tell you. And it was easy for them to shut me down because I was a first-year faculty member. And I thought what we did instead was we said, okay, hold on, let's look, let's back up, let's compromise. And we looked at our labs, and there was an outlier on the labs. And the outlier was ionized calcium. Ionized calcium was more expensive each time you ran it. And we ordered it all the time at Parnassus. And we never ordered it at San Francisco General, even though the same residents rotated there. So we're like, oh. And so we said, does anybody have any war stories about ionized calcium? Can we decrease that one? People were fine with decreasing that one. And so we did I reduce iCal. And we said, draw ionized calcium only when needed. And we did this whole campaign, and we changed the order sets, and we like gave people feedback and all this. And like, yeah, we reduced ionized calcium. And I'm like, okay, who cares? You know, is that meaningful? I don't know. But 2 years later, Dan Wheeler came, resident in 2015. And Dan Wheeler said, I want to decrease the daily lab as my resident project. And I was like, Dan, dude, get ready for the war stories. And they didn't come. I think they didn't come for a couple of reasons. One, can't say no to Dan. And like Dan was a resident, right? Like not the first year faculty member who it's like, no, dude, we're not doing that. It's like, oh, this is your resident project? Okay, sure, yeah, let's support you. Two, the whole world had changed. Choosing Wisely, we had external validation. Other places started to do the work. And this is the part I don't have evidence, you guys just trust me. But I think the culture started to change where we're like, oh, we can talk about labs. We can decrease labs. We can give feedback on labs. So the I reduce iCal got my toe in the door. But the other important thing that we did that we had learned was we said, let's focus on outcomes that matter, that are encouraging to our colleagues and our patients. Patient-centered outcomes. Because most of the projects around the country that were working on decreasing labs, like Hopkins published this thing, because of course they did, and they showed this, money that they saved. And essentially when I dug into it, I'm like, you guys just made Chem 10s, Chem 7s, huh? Like, does anybody care about that? You save like 3 labs on every lab, and you're like, but not really. If I'm in the hospital and you wake me up at 4 a.m. with a needle, run all the tests. Like, you already woke me up, already paid for the day. That's not meaningful. So instead, Dan led a project called Think Twice, Stick Once. He made these pins that he handed out, and all his friends put on their white coats. And the idea was, we didn't measure the number of labs, we measured the number of phlebotomy draws. The number of times your patient was stuck with a needle in the hospital. And we fed that back to the residents. And we changed the culture, the oversight, the system, and the training in order to decrease the number of times we stuck patients. And I know it doesn't look that impressive, but we improved by more than 2 standard deviations and published it in JAMA Internal Medicine. And it's become part of the culture. They think twice, they stick once. All right, I know we're up against it. Less than 5 minutes, I'm going to talk about supporting change through role modeling and systems. But hopefully you're seeing these examples. Remember, what we're trying to talk about here is leading from where you stand, no matter where that is in the organization. Leveraging learners to help lead, despite being learners, but because they're learners, creating that pipeline of change agents, and then using key elements to influence, wielding that power effectively to establish credibility, to frame for the common ground, to match the emotional energy, and to use both stories and data to get our point across. I heard someone joke once that leaders love to talk about empowerment. Like, we'll just empower the residents to do this. And oftentimes what they mean is empowerment is code for you're on your own. Like you're empowered, so you're on your own. That's not the message. We need to create the environments in which this thrives. And we can do it through role modeling, which is critical. Role modeling, like influence, is something you can't not do. The only way is if you're aware of it or not. So we're role modeling all the time. And so we need to be effective at it. One big program, not big, small program, but one big effort in doing that sort of intentional role modeling is we started this different kind of leadership routes. It's actually what I did yesterday morning before I got on the plane to fly here. So we used to do it every week. Now we do it twice a month since COVID. But Thursday mornings, a group like our chair, our associate chairs of the department, our chief medical officer, our old dean of the med school used to come with us. We have an interim dean right now who hasn't come yet, but a group of us meet and we actually join one of the teams. We don't walk around and just say like, how's everything going? We actually go on rounds with the team and we hear about patients. And yesterday we heard about patients that they were struggling with. Like this patient has new lupus and new lupus nephritis and they're undocumented and they don't have insurance. How are we supposed to provide them care? We've got our chair and our CMO. They're trying to help them solve these gaps. It's been really effective. We bring that system thinking to the bedside, but we also bring the bedside to the systems thinkers. Because my chair and others, they're like great clinicians, but if they sit in their office all day, it's super easy to solve problems that they don't even know exist. Okay. And our students have led from where they stood because as part of our STARS program, they started this program called the Choosing Wisely STARS Award, Clinician Excellence Award. Because I told them, remember when I talked about STARS, I said the students go back and they start all these like educational initiatives. Well, our students are like, aren't you the assistant dean for healthcare value? That's like your job, right, dude? Like, what am I supposed to do? And I said, well, I still really need help. Like I can teach the stuff, but how do we create that culture? How can you help me reinforce what you actually see in the clinical environment? Because I know it's not what I teach in the classroom. And so they came up with this idea that they award their clinical teachers, residents and attendings during their clerkships who support them in choosing wisely and value, whatever that means to the students. And at the end, they nominate them during the clinical year. And at the end of the year, we give them an award at our big symposium, educational symposium with the dean and everyone there. I send a letter to their chair and they get these little pins that the students made. And it's really meaningful to them because it comes from the students themselves and it reinforces the behaviors that we want to see. And that's leading from where you stand, leading up, managing up. So that's what we talked about today. It's again, leveraging learners as leaders, key elements to influence effectively, supporting change through role modeling and systems. So I would end by saying, do you have any questions? I'm just kidding. What questions do you have? But thank you. And I will, like I said, I'm here all afternoon. So unfortunately, I think I'll have to take your questions during the break and offline, but thank you so much.
And so we're going to feature we're going to feature the top 2 student and the top 2 and resident presentations for the day here in these categories. So each presentation will include 10 minutes of presentation time and then 2 minutes for Q&A. Sorry will help me keep time and we'll raise something at 2 minutes for our presenters. So you know kind of your 2-minute warning. 5 minutes, I'm sorry, 5 minutes for Q&A. We will give you a 2-minute warning, 5 minutes for Q&A. And then during that time, if the audience can hold their questions for the Q&A, that would be wonderful. And then if you are on Zoom, if you can maybe raise your hand or type the question into the chat, that would be fantastic. Right, so moving forward. All right, so congratulations to the top 2 resident fellow abstracts. You can read them here. Improving transition planning to adult care and diabetes clinic. Primary presenter is Erica Wee. Please thank also the mentors and contributors as well. And then encouraging safe discontinuation of continuous pulse oximetry prior to hospital discharge by Dr. Jeremy Beyer. All right, so we're going to start here with Dr. Wee.
Hello, everyone who's present here, and as well as those watching virtually. So I'm Erica Wee. I'm a second-year pediatric endocrinology fellow at Children's Mercy. And in behalf of my co-authors, I'm here to present on our quality improvement project entitled Improving Transition Planning to Adult Care in a Diabetes Clinic. So diabetes mellitus is a chronic condition requiring complex level of self-care. Therefore, it's very important for a pediatric diabetes clinic to offer support and prepare adolescents for success during transition. So transition here is the time wherein these adolescents, or should I say emerging adults, are beginning to take more responsibilities in all areas of their lives. So they're thinking about college, moving out, and doing all adult stuff. So this is important just because sometimes they forget that they have diabetes, and this could lead to suboptimal diabetes control and the occurrence of complications. I just want to point out that transition in here is not the same as transfer. Transition is the process that ends with transfer. Just to give everyone a background, so the process for transition planning in our diabetes clinic includes 3 major steps. So eligible patient, that is for this project, we included diabetes patients over age 17 years without transition planning documentation for the past 1 year. They ideally complete a self-reported transition readiness survey prior to start of a clinic visit. The provider, that is either a physician or an APRN, reviews this survey and provides discussion to the patient and the family depending on their needs. And lastly, document this in the electronic medical record or the EMR. So for our baseline, our initial review revealed that an average of 22.1% of eligible diabetes patients have a documented transition plan. And our aim for this project is to improve transition planning in eligible diabetes patients to 50% by April 30, 2020. And for the methodology, so the team brainstorm ideas, we break down the problem, we identify root causes and barriers to transition planning. And in this slide shows our fishbone diagram. And those encircled in red are the areas we focus on. So specifically, lack of awareness of all involved of the procedure, providers not recognizing eligible patients, and also lack of awareness of where and how to document in the EMR. So based on these areas we focus on, we developed and implemented countermeasures, which we think were easy to do and at the same time will provide high impact on the outcomes of this project. So everyone involved, that is providers and certified diabetes educators or CDEs, were notified of the interventions and countermeasures through email and department meetings. We reviewed our transition planning documentation data monthly, and we regularly gathered feedback. And for our results, so this slide shows the run chart of our transition planning documentation. Just to orient everyone, the x-axis is the time period in months. The y-axis is the percentage of eligible patients with transition planning documentation. The green dotted line is our baseline of 22.1%, and the red dotted line is our goal of 50%. And the yellow or the gold line is our monthly documentation rate for eligible diabetes patients. So those in the yellow boxes are the different countermeasures or interventions we implemented, and the arrow is pointing at the time that they were implemented or started. So for cycle 1, so we place like a reminder notification in the electronic medical record for eligible patients with upcoming follow-up appointments. And roughly after a month, we were able to implement and develop a smart text documentation in the EMR for easier documentation, and at the same time to remind people the need to document it. So as we can see, after 2 full cycles, we noted that there was an increase to 26.4% with transition planning documentation. Feedback at the time noted that time was a factor. There's a lot of things going on with, other maybe more urgent things to discuss during a very short clinic visit. And like we thought, and the other feedback was like maybe reminding everyone or putting a notification that this patient is eligible will improve flow, discussion, and documentation. So we eventually developed a preclinic huddle, which is basically a quick huddle between the providers and the diabetes educator for that certain diabetes clinic to review eligible patients at the start of a diabetes clinic. We trialed this with 2 of our providers as a small test of change before full implementation. Both of them thought that this was a helpful intervention as an extra reminder just before the start of a clinic day. However, this was put on hold, was temporarily held because of the temporary return to telehealth visits due to the COVID-19 precautions. So during telehealth, our check-in process changed. A lot of technical issues frequently occurs, which further limit the time of the clinic visit. And then we just recently resumed the preclinic huddle intervention with all providers. And we have not reviewed yet our data for the month of April. So in conclusion, our data show a positive trend in results, and we were consistently above baseline, though we didn't make it to our goal. We are continuing evaluation of interventions, countermeasures, and monthly data collection. The transition team is also improving education planning to improve purposeful transition discussions. And ultimately, our goal is to establish transition planning as a routine part of adolescent diabetes care in our clinic. And this is the reference used for this project. And I want to acknowledge my co-authors, Dr. Erica Sars and Dr. Lindsay Baldridge, who are my co-fellows. Dr. Sonali Ravi, who's present here, who's our primary mentor. The Diabetes Transition Work Group, which is a multidisciplinary team whose members are listed here that are not authors, whose ideas and feedback help shape this project. The problem solving for fellow coaches. This is a GME curriculum at Children's Mercy for fellows in relation to quality improvement. We want to thank our coaches who guide us with this. Our fellowship program director, Dr. Joseph Cernich, and the endocrinology clinic RNs who work hard to reschedule some of my fellows clinic patients for me to be present here today. We also want to thank Dr. Ryan McDonough, who's one of the pediatric endocrinologists and is our Cerner EMR expert who helped us develop the smart text documentation template. And thank you all for your attention. I am glad to answer any questions.
So now we have about 6 minutes for questions. We have a little extra time. I'm going to see if I can get this microphone to work and pass it around. If the audience has any questions. I can turn that. There's actually audience mics, so I'll turn this little red button, turns green, and we can hear through the mics. Perfect. So does anybody have any questions?
Yes, I do. I wanted to ask, what does transition planning look like for patients?
Okay. So basically, as I showed the process, what we were thinking or our idea was of it, like they answer the transition readiness survey. So basically, the transition readiness survey has some questions related to transition about medication, about insurance, where they need help, or do they know how to call their diabetes doctor or the diabetes clinic if they have any questions regarding any of their relation to diabetes care. So they answer those questions, and then before the provider goes into the room, they review the survey, and then they discuss based on the patient needs, depending on what they answered on the survey. As I mentioned in our conclusion, we are developing some educational materials to also help our patients, like what are the most common problems that they encounter, and then document it in the EMR. Yeah, that's like the whole thing on this project. That's what we are thinking of.
And very nice talk. I'm a PhD, so I'm gonna ask a this question. So I have imagined for transitions in care for individuals who work children's hospital. Parents have come a long way to bring their kids to children's hospital because that's areas of care. But when they make the transition to adult care, I'm assuming that they would want to see physicians or clinics in the area where they live. So does part of the transitions in care involve connecting them with specific physicians or groups in the area where they live, or making recommendations for areas that you know will take the patients with them?
So yeah, yes, our clinic has a list of like adult providers, at least in the area, and they can call their insurance to determine which of them is covered. And yes, yeah, I mean, we basically don't tell them which clinic they go. They can choose from the list that we provide them.
Clinics, because while I found as a mother with children with physicians, is you call 20 different places to try and get somebody that will take it to the clinic. So sometimes it's very a new patient. So sometimes it's very, it takes a long time. So it's very upsetting as a parent to have to go through that.
Yeah, that's a good question. I am not sure about that because I mean, we all know that it depends a lot on the insurance, and that's why we wanted to start this a little early. So in our clinic, we can see our patients up to 22 years old. So if we started at 17, they have a lot of time to prepare for that.
Dr. Reed, in your transition team or in your planning, do you include patients and families in the process of how we do the planning for transition?
Well, so far right now, no, but that is a good thought, yeah. Yeah, thank you.
Are there national benchmarks for transition plans among pediatric endocrine practices?
As well, like Pediatric Endocrine Society provides some guidelines on how to do this, but the pediatric diabetes clinics practice differently. People have different resources, so it really, you have to tailor it to your particular clinic. That's what I do.
You said, for example, your target for 50% of patients to have transition plans. I wonder, outside of your institution, how others around the country do. It's whether that's something that everyone sort of struggles with.
Yeah, I think from what I know and based from what I have read, some of these clinics, they have basically like a transition diabetes clinic wherein the patient come in just to discuss transition, and they don't really deal with the diabetes part or like changing their insulin regimen, look at their blood glucose numbers. And some of them have like a transition coordinator as well, who specifically just look at that, follow up with patients, help them with what they need.
Obviously, diabetes is a big part of your patient population, but what about the other diseases? Do they require transition management?
Yes, definitely. I know like one of my co-fellows is working on something related to Turner syndrome. So a lot of these kids, I mean, they live longer lives now. They go to adults. So there's also a project regarding that. And yeah, there's a lot of other endocrine conditions that will need transition planning. But for this project, we specifically focus on diabetes issues.
How much time did you spend on this project, either in hours or in months?
How much time? I'm not sure. Wait. So basically the idea, as I mentioned, like this project has been going on before even I started fellowship. There's a transition working group in our clinic who's working on this. We basically just let the very idea of this started because of the problem solving for fellows. But all of my co-fellows and me are becoming interested in it, and we are planning to continue it until we finish fellowship.
Thank you very much.
So now we'll go to Dr. Byer, encouraging safe discontinuation of continuous pulse oximetry prior to hospital discharge.
Pick up the mask, that way we can see my skincare routine. Hi, my name is Dr. Byer. I'm one of the pediatric residents at Children's Mercy, and I would like to briefly discuss alarm fatigue and my project titled Encouraging Safe Discontinuation of Continuous Pulse Oximetry Prior to Hospital Discharge. So as you know, alarm fatigue has gained increasing notoriety over the past decade and even made national news in 2010 when the Boston Globe published an article titled Alarm Fatigue Linked to Patient's Death. This article described a 60-year-old individual who suffered a head injury from a fallen tree branch and was subsequently admitted to the ICU. One morning, over the course of several hours, he experienced a rapidly increasing heart rate and falling oxygen saturations. Finally, a bedside clinician responded after a critical alarm indicated that the patient had stopped breathing. An investigation was undertaken and found that 10 nurses on duty could not recall hearing the alarms at the central nursing station or the scrolling alarm messages on 3 hallway signs. Sadly, despite resuscitation efforts, this man sustained irreversible injuries and was removed from life support several days later. This event was published in the Sentinel Event Alert by the Joint Commission in 2013, wherein they noted nearly 980 alarm-related incidents from 2009 to 2012. And alarm fatigue significantly impacts children's hospitals as well, where we have identified continuous pulse oximetry, CPO from here on, as the greatest contributor to alarms and therefore alarm fatigue. This is further evidenced by our admission rates, in which 50% of children admitted to med-surg units are placed on continuous pulse oximetry for CPO, and 90% of pulse oximetry alarms are non-actionable, meaning that they are either invalid and don't actually reflect a physiologic state, such as like a happy bronchiolitic, or they're nuisance, and although they reflect a physiologic state, it is non-actionable or doesn't require clinical intervention, such as someone briefly deciding to 89, 88%, and then resolves. This still seems by an alarm. So Children's Mercy has established a multidisciplinary alarms committee that is sought to evaluate the impact of alarm fatigue on our units. And in 2019, we identified over 1 million pulse oximetry alarms per year. That's 30 pulse oximetry alarms per patient day, or about 1 alarm every 10 or so minutes for a bedside nurse with 4 patients. And again, that is just pulse oximetry alarm. Unfortunately, roughly 40% of these alarms are for oxygen saturation between 88 to 100%, which we would generally consider non-actionable. Now, our alarm committee has already implemented several measures, such as adding indications for CPO use to reduce the initial ordering frequency of CPO, and it has worked, as we've reduced our count from 30 per patient to 21 per patient days. However, we have yet to evaluate how effective our institution was at discontinuing CPO when it was no longer indicated. So from January to August of 2021, we evaluated 2,600 admissions to the general pediatric residency teams. We found that 48% of these admissions were placed on CPO at some time during their stay. And of this patient population, 95% still had an active order at time of discharge. Now, we can rationalize that active CPO orders at the time of discharge and patient who's well enough to go home represents overutilization and equates to excess alarms. So for our global aim, just to review, we are hoping to mitigate non-actionable alarms by de-implementing CPO when it's no longer indicated. And for my specific aim, we are hoping to decrease the percentage of patients on the resident general pediatric teams with active CPO orders at time of discharge from 95% to 70% by January of 2023. This roller is getting me. In review of the possible etiologies, we have identified several barriers on the provider side that may influence CPO discontinuation. One such barrier is providers couldn't easily tell what frequency of pulse oximetry was ordered without having to modify the order itself. Another one is there was no effective prompt on ground to discuss what monitors were active and necessary. And then lastly, there was yet a provider workflow in place to review active orders or active monitors and indications for discontinuation. So, let's see. Okay. Awesome. For my first PSA cycle, we modified the resident rounding tool to include icons identifying patients with continuous pulse oximetry orders. This is a clip of a resident rounding tool that we utilize on rounds to accurately display or record information on the patient. Highlighted in yellow, we see that there is now a monitor's order icon with SPO2 indicative of continuous pulse oximetry ordered. Okay, on our second PSA cycle, we refined the pulse oximetry order and the electronic health record and increased the visibility of the monitoring frequency. As you can see, you have the oxygen pulse oximetry order, the time it was ordered, and now the frequency continuous pulse oximetry monitoring, or it would stay intermittent depending on what was ordered, and that was not there before. So following these two PSA cycles, I have the results, which is a P chart illustrating the outcome measure, the percentage of patients with CPO still active at time of discharge. As we can see, we have a control chart with our upper and lower control measures, our individual data points, and our mean of 96%. And following the first two PSA cycles, there was no special cause variation despite these low reliability interventions, which has prompted us to get a third PSA cycle that I will discuss shortly. So, in review of our balancing measures, we hope to evaluate the association of CPO usage and code blue events or high acuity transfers. Specifically, we track such incidents that occurred without a CPO order in place. So, as you can see, we have the percentage of patients that had a CPO order in place prior to the code blue or high acuity transfer. And to the right, we have our p-values, which did not show any statistical significance or harm from our intervention. Okay, so in review of our limitations, some studies have not, in review of our limitations, we know that some studies have not found associations between decreased CPO use and the reduced lung count or length of stay. We also know that what is ordered is not necessarily what is reflected at bedside. Unfortunately, with the COVID-19 pandemic, we know that there was widely varying instances and a lot of provider uncertainty on how do we treat these COVID patients and specifically how do we monitor them. As I only evaluated the pediatric residency teams, we know that there was a monthly turnover of residents with variable time between general pediatric months, which can influence our efficacy in lethal loss. The data was not stratified by race, ethnicity, language, or social determinants of health, which we know can consciously or unconsciously impact our performance and outcome measures. And then lastly, the balanced measures had quite wide confidence intervals due to the low frequency of events. Okay. Yeah, so in conclusion, improving disability of the pulse oximetry order frequency was not associated with earlier discontinuation of CPO. And as this was a low reliability intervention, it had those previous studies which have demonstrated that low reliability interventions are not sufficient to change provider behaviors. And then lastly, balancing measures did not change from baseline to intervention periods. In future direction, we hope to initiate PSA cycle 3, which will utilize the REHR program to automatically identify and flag patients that may qualify for CPO discontinuation. This is illustrated by a red alert that is not interrupted on the top right of the patient's shading chart. If the provider chooses, they can expand this alert and it will notify that there are either discrepancies between what is happening at the bedside and what is ordered, or it may alert them that the patient may qualify for CPO discontinuation if they've been on room air for X amount of hours and hypoxemia was the indication. Guys, this scroll is not working for me. Okay, I have nothing to disclose. In acknowledgements, I would like to acknowledge Isaac Jonas in the Office of Clinical Decision Support who provided me with that data. I would also like to acknowledge the Advanced Quality and Improvement Track part of the Berry Institute, and the pediatric residency at Children's Mercy for their continued support. And then lastly, Dr. Allen and Dr. Walton, who provide oversight for our Max committee. Here are my references and any questions.
When the order popped up that patients were on continuous, was there any mechanism that it had to be reordered? Or did it just pop up as a notification tool?
Can you repeat that one more time? I'm sorry.
Yeah, let me take this off. When the order popped to notify that the patient was on continuous oxygen, was there a need for renewal of that order, or was the purpose of it to just inform that patient was on that?
On the PSA cycle 3 for future directions?
Yeah.
It was just to notify that that patients were on. So the alert is designed to recognize patients that have discrepancies between what is occurring at bedside and what's ordered. And then 2, it can alert providers that the patient may qualify for CPO discontinuation.
Was there any active process to renew it? In other words, the thought process, does the patient still need it?
Yeah, so I think that is the second arm of that, and it will be recognizing patients that might not need that order.
Because what we found, at least on the adult side, many orders were made, and unless there was an active decision to discontinue that order that was started, it just never happened. So there either had to be a time stop on the order or an active renewal to actually make change within the hospital.
Okay.
Does that make sense?
Yeah, so you're saying that at baseline, perhaps why we still had 95% of patients with active orders is because there was no indication to discontinue it.
Right.
Gotcha. So I recognize that there isn't a stop time on our orders, nor is there any alert that currently flags providers to discontinue CPL.
That might be a process that you could include in the future.
Yeah, so on the third PDSA cycle, that non-interrupted alert that'll pop up on the right side of the patient's chart can flag providers if the patient qualifies for CPO discontinuation.
I think to build on that, the point is so there's this concept of loss aversion. It feels like you're taking something away, even though it's unuseful and it's like beeping and driving everybody nuts. Like it's really hard to stop something. So you want to replace it with something better. And so either having them like reorder it, or like my colleague Vinny Aurora, when she tried to get people to let people sleep at night, instead of, she tried to say like, don't order vitals at night, don't order these things, and got nowhere. And then they created a sleep order bundle, like order set, and said, actually do this because it's better. And so for patients who qualify, order the sleep set, and the sleep set like replaced the other orders. But it's a really tough, it's a tough one. And I just made a comment and not a question. Sorry.
No, that's really good. That's really good consideration.
Do you have a question, sorry?
I have a question from the virtual audience. So the question from the virtual audience is, how involved are the RTs in decision-making around this?
They're very involved. Oftentimes they help lead it, depending on the indication for pulse ox and the diagnosis that is currently involved. They are also involved in the committee. We have one of their directors involved in the committee.
Okay, we'll go to Jackson and Dr. Carver.
One of the ways we reduce cognitive the experience to have during round a consistent question every single day that doesn't take still need public evidence. And I wonder if on rounds, if that question is asked every single day for somebody on.
So ideally, the answer would be yes. In reality, the answer is no. So we've tried to implement in the past quality improvement measures to ask standardized questions of each patient to make sure that we need IV access, we need continuous monitors, X, Y, Z, and it has not taken hold and it's not routine. But it is still in process and hopefully will take hold soon.
Very good.
Thank you.
Okay. So
95% really high to me. What, I saw your goal was to get 70%. Is there some, obviously there's variations, but it's some indication of like, you know, out of however 100 kids hospitalized, you know, 60 or in respiratory disease, obviously there's other indications for continuous for CPO, but it sounds like probably the CPO doesn't need to be started on some number. I think it should be much higher than 5%. So do you have an idea of what is the average number of, you know, a percentage of patients that like really should ever be started on it? Because I agree, it's hard to stop it, but is there a way to just stop it from the beginning?
So that's hard to say. I don't have that number,
Yeah.
frankly. I don't know what percentage of kids are admitted that are placed on CPO and probably shouldn't have been placed on CPO.
That's a good question. It reminds me a lot of the CLABSI work, the CLABSI toolkit, you know, that have come out, which is just don't put it in at all. And, you know, moving it from that initial percent. And then one last question, Dr. Edward.
Great question. If you, I forget what percent of patients you said that have, if the pulse ox drops to 80% or higher, then it's not actionable. Can you reset the alarm so they only go off when they drop to 87% and lower, or 85, whatever you think is that actionable percent pulse ox?
Yes, so we've done that already in part of our improvement process that was kind of undertaken by my predecessors. Originally, the alarms would go off when the patient got over 90%, and we reset the alarms so they shouldn't go off below 80% or so. The idea though is, you know, what is safe? And it's still questionable on like what is safe and how long is safe. And a lot of that research is based off of the theoretical oxygen association work.
Thank you very much.
Thank you.
All right, so now we're going to transition to our student abstract. So we have two abstract presentations here. So first I'm going to invite Wes Wesky to present improving chosen pronoun and name displays in the electronic medical record to decrease misgendering of gender diverse patients. And also presenting with Kyle Top, is that correct? Yes. Perfect, thank you guys.
This one, so we don't have to do any off.
Hello, everyone. I'm Wes, and I use they, them pronouns.
I am Kyle, I use he, they pronouns.
And today we're presenting our project improving chosen pronoun and name displays in the electronic medical record to decrease the misgendering of gender diverse patients.
So 70% of gender diverse individuals reported facing healthcare discrimination. And what is gender diverse? So gender diverse is a term that describes people whose gender identity falls outside of cisgender man. And we have this neat little infographic up here. It's called the genderbread person. So up top, you see brain, and that refers to kind of gender identity. And that's, you know, our own internal perception of it. So I think internally man for myself. And the next question is how I present that to the world. So I dress in masculine clothing, and I also express other characteristics. So I have a tendency to kind of have an appreciation for the arts. I love to bake, I love to garden, and those are considered feminine and stereotypically shouldn't necessarily be that way. But despite that, I still consider myself to be masculine. So gender identity and gender expression are related, but kind of separate. And then sex is, you know, what we learn in anatomy and development constantly. So to go a little bit more into the what gender diversity includes, there's a few different demographics that we have selected to talk about. So transgender refers to people whose gender identity doesn't necessarily match what we would expect at birth. So if somebody identifies as a woman that at birth they were assigned male, that would be considered transgender. Non-binary is when the individual doesn't necessarily subscribe to either the concept of man or woman. They fall in between or outside. And then gender non-conforming refers to expression, and those people express in a way that doesn't necessarily fall into the societal expression of identity. So moving beyond that, gender diverse people often have a chosen name that differs from their legal or birth name, and that's about 2/3 of individuals. Their sex assigned at birth may differ from their gender identity and may not indicate their correct pronouns or prefix. So chosen name and pronoun are not clearly displayed in any electronic medical record, and this results in the use of incorrect pronouns, which is known as misgendering, and the use of the birth name rather than the chosen name, which is known as dead naming. And both result in adverse health outcomes and underutilization of healthcare services. So we just have a few quick examples for this. So this patient's birth or legal name is considered Jessica Johnson, but their chosen name is Aiden Johnson. Pronouns they use are he and him, and the title is Mr. So we wouldn't say Mrs. Johnson, we would say Mr. Johnson. We wouldn't say Jessica, we would say Aiden. And then when we discuss about this patient to other members of the healthcare team, we would use the pronouns he and him and not necessarily she or her. And then the next patient, we have Dante Jones. Their chosen name is Phoenix Jones. The pronouns are they and them, and the title is mix. And mix is just a gender neutral honorific, not necessarily Mr., not necessarily Mrs. And we would refer to them as Phoenix, and then they and them with other members of the healthcare team. So gender diverse patients are often misgendered or dead named in healthcare settings, and contributing factors to this that we noted were the EMR, patient identification stickers, and patient wristbands do not display chosen name or pronouns, inadequate and or limited training on the use of gender diverse patients. The patient portal and patient letters address the patient by their legal name rather than their chosen name. And our aim was to improve the display and use of chosen name and pronouns to reduce naming and gendering errors. So right down at the bottom, we just have a sample banner of what we were working with before we made some changes. So this patient's name that is listed is just Brad, last name is ZZS, and we'll kind of go into more details on the difference in display.
For methods, the first thing that we did is we started brainstorming all the different things that could be contributing to the misgendering of our patients. And identified 4 main categories. So training, this includes things like many people don't understand the current display, and then also knowledge on how to address and why it's important to correctly address our gender diverse patients. Systems, the way we do things. So in our clinic, there's a protocol of using patient stickers, which only have the patient's legal name to call them up in the waiting room. That's what leads to a lot of problems. And then no system of collection of pronouns. EMR display, it's hard to differentiate which is the chosen name and it's not listed everywhere. And pronouns are not displayed at all. And then technological complications, there's no place to input the pronouns. And then all the places where only legal name is to. So we came up with 3 main interventions. Our mentor, Dr. Ewan, started with clinical staff training. This was through regular reminders via email and meetings with our clinic staff. And then we also weekly called the IT help desk to talk about the changes that we wanted to see. And then lastly, we initiated regular meetings with Dr. Hackman, the Chief Medical Information Officer at University. First, we on the patient banner, which you saw an example of before, we now have the chosen name and pronoun in parentheses. We currently have the pronoun in the same field as the chosen name until we're able to find a separate field for that. So that's what we decided to do so far. On the schedule view, we now have chosen name and pronoun in parentheses, as well as if the sex assigned at birth and current gender identity do not match. You'll see this blue eye icon. And on the next slide, you'll see the layout of that. So administrative sex is the word the EMR uses for legal sex. And then you have sex assigned at birth under that, and then gender identity, which is current patient's gender identity. Some of the terms used in this field are a bit outdated. Like most patients would not prefer female to male, or male to female, they would prefer trans women or trans men. And then finally, we are currently in the process of reorganizing the patient wristbands to look more like this view. So In this example, the preferred name is Conway. We now have that at the top of the patient wristband. This is where the legal name used to be, and we move the legal name down to the bottom of the wristband.
So in conclusion, using patient's chosen name and pronouns is essential for gender diverse patients, and we do have a few remaining challenges. Most faculty and staff do not know how to add the chosen name and pronouns to the banner just because it's a very new change. The parentheses may confuse people, just in reference to like, is this a nickname? Do I have to use it? Or is this the chosen name that I should use for the patient? Many do not understand the eye icon, and then updating patient stickers in the patient portal letters is still in the process because that's a large source when we're communicating with the patients of dead naming and misgendering these incorrect honorific.
All right, lastly, I want to emphasize that using the correct name, pronoun, and title for our patients is the first step in providing affirming and inclusive care for all of our patients. Future directions, we want to expand this work to every single healthcare setting here at University Health and beyond. We'd also like to use surveys to collect data on how our changes are working, both from the perspective of patients and from the healthcare team. We're working on instituting pronoun badges on our hospital badges. This communicates safety to our patients and then also to the healthcare team as well. We want standardized longitudinal trainings for every department. And we also want to develop an organ inventory. This is a more inclusive way to figure out like what kind of screenings each patient needs. And so this is another important thing to be more inclusive of our gender diverse patients. And then lastly, we want to amplify this message. We want to get everyone involved and excited and dedicated to correctly addressing and including every patient.
And then we just wanted to give quick thanks to Dr. Jeffrey Hackman, who was the is the Chief Medical Information Officer. We brought up most of our concerns and changes that we wanted to implement to Dr. Hackman. Dr. Hackman was the one that implemented them. We would also like to thank the LGBT+ specialty clinic, faculty, and staff just for being advocates for the patients and bringing up these issues to us so that we know what we can work on. And we would like to thank our mentor, Dr. Melody Eagleton, who has been our biggest advocate and also and here are our references and Q&A.
You're going to take audience questions. Yes.
So I think one comment and a question. So I think it's really cool that you guys thought about the wristband and changing where people look. So using that human factors design about where people look to get names. I think the biggest question I'd like to ask is, one of the challenges, we may all have great ideas about the project we want to do, but getting the resources to do it is always a challenge. So how did you guys get in the CMIO's door to make this happen?
Lots of complaining. So, I mean, at the end of the day, I think it was just this hesitancy to get the changes in and like, where do we start? What do we want to include? So I think reaching out to IT, which was our initial first step, is probably what precipitated everything else. And I got contact with Dr. Hackman afterwards. And then challenges, I definitely think from my understanding that the main difficulty right now is clarification with billing as to which name, which sex is used, and then that also has limitation on our spaces for stickers.
Yeah.
Great presentation. My question for you is this, and you may have embedded this somehow into your work, but how, with each step along the way, did you incorporate the patient's viewpoint of what they prefer to be on their record and how it will be displayed?
I think a lot of the motivation for our changes came from our individual patient experiences. Dr. Eula Hicks in the LGBT specialty clinic, and then we'd also have many of her LGBT patients in our clinic. So one example is Dr. Eula Hicks walked into a patient who was inpatient who had a wristband on, and it had their birth name right on the top of the wristband, and the patient was tearful and very upset. And so just lots of individual experiences that kind of got us like thinking and motivated about how we can change this. But I do think we would like to find a more formal way as well to quantify like patient experiences and hopefully how we can change.
And if I can add to that too, I think the reason why we implemented these changes so quickly, and we're still kind of trying to collect data on the impact of it, the human rights campaigns, health quality index already shows that 91% of the participating hospital members in the survey already include all this information in some shape or form. So it's just if you haven't had that yet, it was probably appropriate to follow suit. And then there's also been a few studies showing that concordance, so basically matching the name that they prefer to use and the name that is actually used in other legal documents, decreased adverse mental health outcomes by, I think, 32%, and then rates of suicidality by about 28%.
Yeah.
Showing that misgendering affects things like clinic follow-ups or adherence?
So we don't have any individual data on that, but other studies that we've kind of referenced in our reference list, and we wrote on the draft for paper, they mentioned that specifically for teens at least, whenever there's an incident of not being misgendered, they are less likely to utilize either preventative healthcare measures or even just not even going to primary care clinics at all. And that was, I think, 32% of people felt that way, and then 70% of people have also faced that discrimination, which is
Really nice work. Thank you. One question I have is as you think about how this is going to work, it's really difficult to do widespread the terminology and changes something that's changed a lot over the last 10 years. Is there a way in the right kind of record to put on so that you can continue this education and people look at the sex versus whether they're a trans man or trans woman, because many people don't really know what the terms mean. And if there's a way to, as people look on these things and work with patients, that it's an education for the provider, so we continually increase the basic information.
Yeah, I'm not aware of the any current capability for that. I think that would be a good idea. And yeah, I agree that like figuring out and implementing a good up-to-date trainings is definitely going to be a challenge that will need continual work.
All right, time's up. Thank you so much. All right, so last but not least, Julia Snodgrass is going to present hands-on training sessions to improve advanced therapeutic endoscopy techniques at an academic children's hospital.
Good afternoon, everyone. I'm Julia Snodgrass, and I'm here today to present our project, hands-on training sessions to improve advanced therapeutic endoscopy techniques at an academic children's hospital. So, as we know, endoscopy is critical for the management of children with complex GI disorders. Hands-on experience with advanced techniques and new equipment has been identified as a potential area of improvement at Children's Mercy Kids Study. Our aim with this project is to improve provider scoring on a practice-based test on technical aspects of these advanced endoscopy techniques by 20% over pre-practice session testing. So the areas that we really wanted to focus on was hemostatic techniques, pelvectomy, and esophageal dilation. Specifically, things like safety measures if a colon or a valve is perforated, how to stop the bleeding and control that, situations like that. And newer techniques that were safer for the patient, had better recovery time, things like that was what we were focusing on. We set up a multi-station model. There was 5 stations with hands-on demonstrations with providers at each station to teach the techniques that they were best at. And we had a pig stomach model and animal-only endoscopes on loan. Demonstrators at each station provided their own test questions. Our outcomes measure was improvement test scores. We had a goal of 20%. Our process measure was the percent of total providers and trainees attending this activity, our goal being 50%. And our balancing measure was the amount of time committed to this training, and our goal being less than 2 hours. Attendees also had the option of rating the utility of the activity on a 5-point Likert scale. So for this, we really were looking at the barriers preventing providers from expanding their skill sets and expanding the types of techniques and equipment that they use in procedures. Some of the things we found was the cost, there wasn't a very cost-effective way already established at Children's Mercy to explore these. The time constraints, obviously, everyone's schedules are busy, and finding a safe non-patient opportunity in a learning safe environment. So I know it's very small print, but here's the example of the 12 questions. They were identical for the pre-test and the post-test that we gave out to providers. For example, some of the things that we asked was, what age is it safe to do banding techniques on? Or what color of band indicates that it's the last band left in your supply? Things like that to really get a hold of some technical aspects that they might not learn in a more patient-centered environment. So to set up this endoscopy model, we used a plastic storage bin. It had a hole cut in one side for the esophagus to go through. We had an animal-only endoscopes at each station that were on loan. We have porcine, esophagus, and stomach at each station as well. We put bubble wrap around the esophagus and stomach to recreate intra-abdominal pressure, and ice packs in some of them at stations that had ablation techniques, just for temperature regulation, make sure we didn't burn through any plastic bins. So we had 14 providers come to our activity. That was 70% if we adjusted for providers on medical leave. And then there was 5 fellows, 4 attendings with 6 to 10 years of experience, and 5 attendings with over 11 years of experience. That was over our goal of 50% for our process measure. Our balancing measure was at goal, with all respondents reporting 2 hours committed to the activity, and 100% of participants rated the activity as very useful on the Likert scale. Testing scores improved from 51.3% at baseline, and then an average post-test score of 76.6%. So definitely above our baseline. And one thing I wanted to add was that I had a very unique perspective, being a student, observing attendings and my mentors and people like that at their own training sessions. And I think the thing I noticed the most was how excited and enthusiastic that providers were. I think as students, we don't really take into consideration the continuity of education, but I think that speaks to the environment that Children's Mercy has established, like a safe learning environment where they can communicate, still be competitive, and have fun learning in the process. So in conclusion, our provider scoring on endoscopy practice tests improved by 25.3% over baseline. However, the benefit was greater for trainees and more junior providers. So future sessions, we want to communicate with the more senior providers and focus on how we can meet their educational needs. We didn't have any disclosures. So does anyone have any questions for me?
The SIM person, I'm going to kick it off with the first question. Was there any thought given or consideration given to doing a skills-based pre and post test as opposed to a medical knowledge-based pre and post test?
We've talked about doing that in the future. We didn't want providers to feel like they had to perform well. We wanted them to explore the new techniques first, especially because this was their first exposure to a lot of the techniques and the equipment. But we definitely discussed that for subsequent sessions.
Yes.
Julia, this is the second presentation I've seen you do today, and I'm struck by how you use process and outcome and balancing measures, and I'm just curious, do you have like specific training around how to set up this QI, or was it your mentor, or how did you apply kind of these QI concepts to this project?
Actually, Dr. Atard, our primary mentor on this project, is very well versed in QI projects and things like that. So he's been a great learning tool because before these two projects, I had no experience in quality improvement. But yeah, thank you. Oh, yes.
Can I ask, how was this funded? How are you able to get all this stuff?
This was, the 2 hours that we allotted to this was actually already an administrative time slot set aside. We didn't want to take the time away from patients or already set up encounters. So if I believe correctly, this was more Dr. Atard's side of the project. This was already funds set aside for administrative learning activities for the 2 hours.
Who purchased the pig stomachs?
That was definitely Dr. Atard's job. I set them up, but.
How much time is spent on this project?
I think the administrative side of it was definitely not taken care of by me because I'm not employed at Children's Mercy. But I think we got there just a few hours before, so 2 or 2 hours at the activity, and then a few hours to grade the papers and set up charts and things like that, and discussions with the other authors. So, and not as long as you think for such a great project that Dr. Atard set up. So like 8 hours.
Did you notice a difference in performance pre and post based on years of experience?
I didn't observe the actual stations because I was picking up the tests and grading the tests and things like that. So I'm not sure.
We're done with questions.
Thank you very much.
Looks like we're getting back on track time-wise. So take a few minutes for a break, or you're gonna go right into it. We're gonna go right into it. Okay. Right on time. Yeah, right on time. Thank you for. Thanks for making it here to the final stretch of our program. We want to conclude the first part of this afternoon with a recognition and awards ceremony. We want to recognize our poster winners in just a minute, and we want to review some highlights of the poster showcase for those who were not able to participate here today. We also have some faculty awards that we'd like to present and hear some reflective words from Rayudu family representative here. So since the program was established in 2014, we have had a growing number of projects over the years, or a steady trend until this year. So we're not quite sure yet what that reason was behind it, but we had over 334 unique projects since 2014. And many of the projects, as you can probably see if you've been with this program over the years, you see not just the number of projects, but the quality of projects have been improving over this time, using stronger methodology and rigor each year over year that we see the program developing. This year we had 40 projects submitted as abstracts with 182 individual contributors representing 8 different departments. And you just heard from our top abstract winners, and I'll explain how this was done, but we want to give one more round of applause to our student and resident fellows. And I want to ask Shari to come here and tell you how you can access the poster showcase.
Hey. Hi, everyone. So I'm going to show you just a quick full disclosure. This video is from last year, but it works exactly the same this year. So if you are interested in viewing our posters and also the videos for our presentations that you heard today, we'll have those all up on the website soon. And so let me actually go back. you just go on Google and you search for the Vijay, Babu, Rayudu Quality and Safety Day, you will find a website for our event that will come up right away. And if you scroll down, you'll see a section for 2022 presentations, student posters, as well as resident fellow posters. And you'll be able to click on all of these links to take you to the videos that will play with the students, residents and fellows narrating their project. So that is for all 30 of the posters that were presented this morning to our judges. And then we'll also have information on there for the 4 oral presentations that you saw this afternoon. And if you're interested in 2021, that's all still there as well, but it works just the same for this year's projects.
All right. Thank you, Sally. All right, so we'd like to announce the poster winners, and if you could please come up here. If you have more than one team member here, we'd like to see you all up here. So the first poster winner we want to talk about is a student poster. So Julie has not passed. And we can have team members, please. Julia was a platform presenter as well. She presented on the improvement of patient experience and pre-colonoscopy cleanout at tertiary children's hospital. Right, next we have Fahad Qureshi, or I think is left. You'll take forward.
I think so.
Yes, okay. So Fahad actually submitted 7 abstracts with collaborators and presented one himself this morning with more back for Chicago 46, the difficult math ventilation, unpacking expertise, judgment clues, and critical decisions in control. And our resident and fellow poster winners, we have Thomas Cochran here. All right, we will inform Thomas and his team for increasing incentive spirometry use in patients with sickle cell disease and Children's Mercy. We have Ruben, very good, Ruben, Joaquin, Ricardo, Almeida, optimizing diabetic ketoacidosis protocol management in patients submitted to the spirometry. So congratulations to our. So for those of you who were oral presenters this afternoon, or if you presented a poster with an audio narration this morning, you can claim credit publicly for your work on your CD by citing your abstract using the following format. We'll have this posted on our website if you need to refer to it later, or you can ask us by email as well. So we want to thank a record of 46 judges who helped this event be possible. So the 40+ abstracts initially submitted were scored by our first round judges. And then we had our top 10 in each category that were scored by our second round. And from that group is how we figured out who our platform presenters would be. I also want you to take note of our judges who judged in our live poster session. I want to draw your attention to Dr. Gopi Asik, who is our honored Quips alumni judge. That's the title we've given you today. And we have representation from across the affiliated programs, including our partners at St. Luke's and the VA and Children's Mercy, and many supporters who have been involved in the program from the beginning. And also want to draw note to several of our judges who are new faculty scholars who will be continuing the year in the program as mentors. This program requires a lot of effort from a lot of individuals. This shows our Quips Consortium governance committee members. That includes steering committee members who meet monthly and the advisory committee members who guide the strategy in our meetings twice a year to follow this meeting here at the end of the day. And what I want you to know here is that there are some very high-level leaders from across different organizations that help drive the strategy. So from CMOs and CMQOs and many other titled individuals here, but we also have medical students, residents, and trainees here to help guide this work. So thank you to all of you for the work you volunteer towards this effort. Thank you to our steering committee chair for a second year of moderating.
Welcome to our new advisory committee chair, Dr. Vijay. To spare us a little bit of time, I wanted to introduce you to our faculty scholars by this screen. They represent 4 organizations across our affiliate programs. And also to introduce you to our new QUIP student scholars, Julia being one of them. And these students are starting this month with the QUIP selected and will continue over the next 12 to 18 months in an experiential longitudinal program with the faculty scholars to hopefully see them here again this time next year. Next, I'd like to invite Dean Jackson up to present the Faculty Mentor Award.
Thank you so much. Well, this has been a wonderful day. First off, I want to thank our keynote speaker, Dr. Morales. That was an inspiring talk that you gave. I think all of us who are engaged in this kind of work learned something new that we're going to take and change how we act and work within this space. So thank you very much for being here. We're honored to have you. Dr. Monteretti, you are terrific. As our endowed Rayudu chair, your work has been amazing. The vision that you've had and the follow through that you've had in achieving the goals of the Rayudu family, I think are spot on. And we're so grateful that you're here. And also for Sari Cantrell, who is your chief colleague in pulling this entire work off. So thank you. Okay, so I am so honored to give out this Faculty Mentor Award. So the award goes to Dr. Rana Alfagali. I'm going to tell you a little bit about her, and I'm going to build on some of the words that Dr. Morales had for us. So first off, I've been so honored to work with her for the last 5 years. I recruited her to Children's Mercy. We've worked together on many, many projects, and I just have such pride in the work she's done. But I want to tell you how she's done it, and this is what I call secret sauce. Her secret sauce is that she's built a foundation for herself in quality improvement and patient safety work. That's the credibility that Dr. Morales was talking to us about today. She's made this the bedrock of her career. It's been leveraged not only on her passion for the work, but her engagement and her follow through, and her belief that this work will transform and improve care. One of our first deans, who's now 99 years old, well, one of our first deans, our first dean at this medical school, who's now 99 years old, had used these 2 words to describe one of our first doses, and that is effortless excellence. And that's, I think, what Dr. Alfagali demonstrates every day. She's the national leader of SHARPS, which is a 57th institution collaborative designed to work toward better stewardship of outpatient antibiotics. And the work she's done has decreased blood culture contamination rates, increased guideline concordant management of underlying diseases, decreasing duration of antibiotics, increasing vaccination rates. The work she's done has been impactful. And she does this, as I say, with effortless excellence in grace, in working with all the mentees that she works with, from students to residents to fellows to other faculty. So I'm so proud of you, Dr. Alfagali. Come and receive your accolades.
I know I'm not supposed to say, give a speech, but thank you for being the best mentor and sponsor a person can wish for. Let me take my hat off. Sorry,
Okay.
sorry.
One more time.
Okay.
Infectious disease.
Gotta get on Twitter. Thanks.
You'll be tennis, right?
Right, thank you, Dean Jackson. Next, I'd like to invite Dr. Dries up to present the Lifetime Achievement Award.
you. First, I want to echo Dean Jackson's comments about what a wonderful day it's been and the value of having such wonderful keynote speakers. It's really inspiring to hear what others are doing and to get the tips on the things that we can continue to do to improve how we look at our quality improvement and safety programs here. It's my honor to present our Lifetime Achievement Award, and that goes to Dr. Lawrence Dahl and his service here to the School of Medicine, to our students and to our patients spans 4 decades. He was here as a docent and as an infectious disease specialist, took a 15-year break, went back to private practice, and then came back 10 years ago. And when he came to talk to me while I was dean about his interest in coming back, it was specifically to engage students in quality improvement projects and the importance of doing that. And the fact that because of the kind of clinical training that we do, this is such a fit for the programs we have here. He has a long history of personal commitment to quality improvement, including antibiotic stewardship, care of people with HIV, and STI screening, among other things. And I think that when you see the engagement of students and the work that our students are doing from the abstracts today, you can see that when he came back 10 years ago, he really made a difference in getting students engaged. And our first Quality Improvement and Patient Safety Day was 9 years ago, 2014. And during this time, we've had about 175 student abstracts and posters. And so I think that and each year more and more students who are publishing in quality improvement projects. So there's no better evidence of the impact that Dr. Dahl has made than what our students are doing and continuing to do. And every year, the quality of the projects improves and the skills that our students have improves every year. So Dr. Dahl, thank you very much for the work you've done, but especially for the inspiration you provided. Great.
Thank you, Dr. Lee. Last but not least, I'd like to ask Dr. Rayudu to say some reflective words.
And I have to get a new photo because that was a lifetime ago. But, you know, I have nothing more to say. Thank you to all of you, you know, especially Dr. Dries and my parents who envisioned this many, many years ago. Holding back tears a little bit because all these presentations, they really, you know, it doesn't matter if it's small, it doesn't matter if it's big, it doesn't matter if you got the results you wanted, it doesn't, you know, or if you did. Every year, it's just a great reminder to celebrate my brother. And I could argue that the work that's been done till now is much, much greater than one person could have done as a physician himself. So thank you all for that and keep up the good work.
And finally, I'd like to remind you of the 10th annual event, which will be the first Friday of May instead of the second Friday because of conflict with graduation ceremonies. And we have the keynote speaker that Dr. Boyes can say we can that well. So please mark your calendars for Friday, May 10th. Okay, well, thank you everyone so much for being here.